Welcome to SOLACI 2019. It's a great privilege to have Dr. Martin Leon here among us, and he's certainly going to share very important information on low-risk patients that will undergo TAVR. He was a true pioneer in this subject and was the PI for one of the most important studies, now expanding indication to lower-risk patients. Mari, thank you so much for being here. My first question to you is that do you feel totally comfortable to expand the indication to lower risk patients, including all ages, or do you think that to start with, we're going to be including patients with lower risk but with higher age?
It's a very good question, Alex. You have to remember that in the two major clinical trials, first, we excluded patients with bicuspid disease, many of whom were much younger. So the proportion of patients that were younger, under the age of 65, was relatively low, less than 10%. So we don't have enough data in the truly younger, low-risk patients to be able to say that this is the best therapy compared to a surgical valve. Certainly, as we accumulate more durability data in the next many years, and we'll be following these patients for at least 10 years, I think in the future that may change. But now, if you're under 65, I would have a discussion with the patient and have them participate in the decision about whether or not they should consider TAVI or TAVR versus surgery.
So that brings me to the second question. We keep saying, we keep hearing that there is so much data on durability on surgical valves, and that it's going to be hard to compete with 15, 20 years, 30 years of surgical valves. What is the reality behind this story? Is that enough data for us to believe that surgical valves is going to last forever?
First, I believe we need to dispel the myth of surgical bioprosthetic valve immortality.
Yes.
The data talking about 10, 15, or 20-year-old durability is on few numbers of patients and a few number of valves. The reality is that most surgical valves are approved and used based upon 3 to 4 year durability data. And we already have at least 10 studies with more than 5-year durability data with transcatheter bioprosthetic valves. So right now there's a disconnect, and there's a difference in the way people look at surgical versus transcatheter valves. In the future, I think this will change, and we'll have standard definitions, and we can apply them equally with both. But at least now, I think there's a lot of hype and a lot of publicity about surgical valve durability. I'm not sure that it's the reality.
Wonderful. So my last question to you. I was stroke, and I was really impressed by the very lower rates of stroke in the Partners 3 and low-risk core valve. Do you think that there will be a role for distal protection in the future? I know that most of the patients were excluded for both of these trials, but what's your impression on protection?
It's a very good question. It's not easy to answer. It's true that in both of the low-risk studies, cerebral embolic protection devices were not used, yet the stroke rates were extremely low. So it's hard to imagine that they would have been very much lower, but there may be other subtle things that can affect the patient over the course of their life, and it's difficult to predict which patients could have a stroke. It's a very random event, and there are very few factors that will tell you who is at higher risk. So even though the stroke rates were low, we still routinely, systematically use cerebral embolic protection in all patients where we think we can easily implant the device. But this will be validated in the future. We're doing multiple additional studies, including large multi-thousand patient stroke studies. And I hope in the next 3 years or 4 years, we'll have much more data to be able to guide our decisions about who to treat with these new therapies.
This was wonderful. Thank you so much, Mari. And again, thank you for coming to SOLACI.
Always a pleasure to be here, Alex.
Thank you.